Next, we will hear from Dr. Bonnie Spring. Dr. Spring is Professor of Preventive Medicine, Psychology, Psychiatry, and Public Health at Northwestern University and Director of its Center for Behavior and Health. She's also the Team Science Director for Northwestern's Clinical and Translational Sciences Institute and Program Co-Leader for the Cancer Prevention at the Robert Lurie Comprehensive Cancer Center. Please join me in welcoming Dr. Spring.
Thank you. It's a pleasure to be here. So I'm going to talk about the design of multi-level interventions to treat obesity. And I'm starting out with reminding us of the social ecological intervention framework. And this is a quote, a description of that framework from a wonderful paper called In Search of Synergy. And the basic premise is that interventions that target, the social ecological intervention framework, the basic premise is that if your intervention targets more determinants at more than one level of the ecological model, you will have larger and longer lasting effect than if your intervention targets only one level. So my question to you is, do you believe this? Well, I hope most of you do, since we're at a session on system science. I believe it, but I have to say that it's a bit more of a taken on faith premise at this point, because we don't have an awful lot of data that supports this argument. What we do have when we turn to the clinical treatment of obesity, and this is the treatment now that is covered by insurance, it's recommended, the gold standard according to the U.S. Preventive Services Task Force, it's intensive, multi-component behavioral treatment for obesity. And I forgot to tell you to advance the slide. So we should be on gold standard obesity treatment. You know what? I'm gonna watch what you are presenting. This is an intervention that was tested in 2002 in a multi-site trial. It had outstanding results for patients with prediabetes. It caused greater weight loss than placebo and also than metformin, and it delayed the conversion of these individuals from prediabetes to diabetes. So what exactly is the DPP? What is in the treatment? Well, you can see it's a packet. It's kind of a sink of components. And the things in the purple circle are the components. It involves 24 treatment sessions. And that's always the most expensive part because you have to pay the camp. The sessions, when it started out, were one-on-one, individual. They were led by health professional counselors, mostly nurses, some dietitians, some exercise scientists. It cost $1,500 per person in the first year, and the treatment was always in person. So over time, we've tweaked these components a bit. Now it tends more often to be offered in group. We now have lay counselors or trained YMCA staff trained by the CDC offering this treatment. The cost has come down. It tends to be under $500. And the most recent thing, which is very important, is that we're finally starting to offer it remotely, occasionally. So if we could go to the next slide. What we decided to do was to take this treatment, which is targeted very much at the individual level, and see if we could recompose it in a way that targeted more levels of the ecological frame. So we still target the individual. We use coaching calls. This is being done remotely with an app and connected coaching, so the app can see the person self-monitoring. And we vary whether we're offering them the usual 24 sessions or to see if we can do this right, could we get away with 12? And we're trying to build self-regulation and self-efficacy. At the next level, at the interpersonal level, we have everyone join the treatment with a buddy, a support buddy. And we vary whether we train the support buddy in how to be supportive. Half get it, half don't. At the next level, the organizational level, we have a very light touch intervention. Half of these people get a report of their progress in weight loss sent to their primary care provider or not. The environment policy level is the one I would really like to play with. I'd certainly like to play with the insurance policy, but it was very difficult for us. What we were able to do was to offer meal replacement recommendations. The advantage of meal replacement is that it makes portion control easier, so the environment becomes a little bit more friendly. Although some look-ahead intervention did provide meal replacement throughout the whole intervention, we thought that wasn't, so we didn't do that. We offered it for a week, and then we made recommendations. So the next slide. What our aims were in this intervention was we wanted to know which of these treatment components contributed the most to weight loss at 6 months and at what cost, because we wanted to use that knowledge to build a treatment package that yielded the maximum weight loss that was attainable for less than $500. And you can see here all of the 5 components I've just shown that target different levels of the ecological model. This is the factorial design. You can see it's very efficient when you're testing these components. You're using the entire sample to test each of them. You also can see that we have everyone gets what we call the core intervention. They get their self-monitoring app and they have online lessons. The next click, please. Here you see that we randomized 562 people in this trial. And this was an entirely remote trial. We never saw these folks at all. At 6 months, our retention was 84%, which isn't bad for an entirely remote trial. So now, which of these things do you think significantly enhanced weight loss? So I can tell you, I was betting on the 24 session, because it's certainly the most expensive. I thought it would be an advantage over 12. That's not what we found. What we found was that training the body to be supportive significantly increased weight loss, and there was a synergy. There was an interaction with the report to the primary care provider. If the person was getting buddy training, giving the report to the primary care doctor further augmented that effect. So so one thing I wondered about was when I saw that the 24 call condition gave us no more weight loss than the 12 call condition, I thought maybe we had implemented the study wrong. Maybe people didn't get the entire dose. So we checked, and I don't think that's the issue. They got about twice as many calls in the 24 call condition. They got about 80 minutes more coaching. So they seem like they got the correct dose. The way I understand it is that it seems to me that we saturated all of their self-regulation training needs in the 12th session, the 12 coaching calls condition. And now where we stood to gain added advantage was by optimizing their environment, making it more supportive, holding them more accountable. And so you see the implication for how we could use this for decision making. So if I were just going by the statistically significant component effects, we're on the next slide now, should say decision making, build treatment package. And we should have the condition 5 highlighted in red. You see that this is the condition that keeps everything off or at the lowest level, except turns on buddy training. It's not bad. We get a 5 kilogram weight loss. It costs us less than $500. Costs us $414. We get almost 50%, achieving 5% weight loss. But if you click again, and you now go to what we get if we add the primary care report to the buddy training and the 12 coaching sessions, now you see that if you had just $10 more, $13 more for this treatment, which costs $427, you can now get an additional kilo of weight loss, and 50% of your sample is now getting 7% weight. But the reality is that in the real world, we have constraints, and sometimes we don't even have $400. We might have $325 if I were running a community clinic that had very few resources. And I had a lot of people in my community who needed this information. What could I do then? Well, I could go click again to the bottom green slide where I just give the 12 coaching calls, the app, and the online lessens, I still get 5.25 kilos of weight loss, and get half of the population achieving 5% weight loss. And look at the value here. I'm paying for this one, the best value, $67 per kilo. So moving along, I want to just remind you of where your working group left off at the Obesity Solutions Conference in 2014. We should now be on a slide that says clinical community integration. And what you see is this aspirational diagram that says we should have a linkage between these three major sectors: care delivery sector, community systems, and the family and individual. So what we have done is we started with putting the DPP in hospital-based or healthcare-based delivery system. And that's how we arranged the reimbursement for it. It needed to be in a medical facility provided by a physician or an advanced practice professional. But, this really didn't work very well. The physicians don't have time. They are paid. They have to accumulate their RVUs. The codes that pay for the DPP don't pay enough to utilize their time well. So what we did was that we moved the DPP program into the community. We are now offering it in YMCAs. It's been scaled beautifully. It's offered at many YMCAs. Many people are trained, but we have a problem of people are not using it. Only about 4% of the population needs it are not using it, and the people who are not getting it are particularly the underserved. And here what you see is the problem of having a place-based program offered. Low-income folks don't have the transportation. They may be working a couple of jobs. They don't have the child care. And so you're disenfranchising exactly the people that you want. So what I think needs to happen is this is where I think we really need some system science help to figure out how to build those linkages across the sector. And we need it very badly. I'll just give you one example of where our not knowing this has really led to a big mess up. Recently, there was a demonstration project trying to use the wonderful population management tools that are now available in most electronic health records to refer people to the diabetes prevention program. It worked beautifully. Masses of people were referred to the YMCA programs, but the uptake was so minimal. What worked much better for uptake was if the clinician was directly referring the person. So you can get scale, but no engagement. We have to understand these mechanisms of trust and linkage that give us what we want. So I'll just conclude by saying I do think that multi-level intervention holds promise. I think we need to understand these multi-level system synergy and the constraints on implementing obesity intervention, and there really are constraints. Maybe we can work past them if we keep building, but at the start of things, there are constraints. And we need to continually optimize for both effectiveness and efficiency within the context where we're trying to roll out. So just to finish, I want to thank my wonderful collaborators, including Linda Collins at Penn State, Susan Murphy at Harvard, Billy Malcolm Cheney at the University of Michigan, and the funders without whom none of this